Good evening, everyone. My name is Nina Vijayvargiya. I am a GI medical oncologist here at Fox Chase Cancer Center, and I would like to welcome you all to this Together Facing Neuroendocrine Tumors event. I would like to thank our patients, caregivers, advocates, and all the guests that are joining us this evening to learn more about neuroendocrine tumors so we can take care of our patients better. Tonight, I and my colleagues will share the latest research and treatment developments for neuroendocrine tumors. Throughout the program, please feel free to leave questions in the chat feature on Facebook, and we'll try to get to most of them today, and if not, later on via email. Before we continue, I would like to take a moment of silence to honor those we have lost to cancer. Please join me. Thank you. I would also like to thank our exhibitors for this evening. It's because of their generous support that our program was possible and we're able to extend it to all of you today. Our gold exhibitors are Exact Sciences, Guardant Health, and Loxo Oncology, and Lilly, and Natera. Our silver exhibitors are AstraZeneca, and our bronze exhibitor today are Ipsen and Tercera Therapeutics. Also, I would like to give a special thank you and a special shout out to the Neuroendocrine Cancer Awareness Network, who we have partnered with in the neuroendocrine tumor community to help spread the word and empower patients and help them with their cause to ensure that each patient can get the best treatment possible. So now, after all our introductions, I will now move over to our esteemed panelists for today. We at Fox Chase take pride in the multidisciplinary team we have to take care of our patients with neuroendocrine malignancies because it's a very complex disease. We will start with Dr. Jason Castellanos from our hepatobiliary surgery program. Thank you for joining us, Dr. Castellanos.
Thank you, Nina. Hi, everybody. My name is Jason. I'm a surgical oncologist. I specialize in cancers of the liver, bile ducts, and pancreas. As such, I've taken care of many patients with neuroendocrine tumors in conjunction with many of the folks, if not all of the folks here on the panel today. It's an interesting disease in the fact that a surgeon may be involved at the outset or maybe later on. And so there's a variety of paths to take. And it's an interesting disease because it really depends a lot on what the patient wants to do and how they're doing, and a lot of their individual, not only clinical characteristics, but values, beliefs, and things going on in their life. So we had a patient in our little, on the slideshow that Nina and I shared, and we had to time her surgery around her job. And I won't get into her personal details, but we were able to do that in this particular case because of all the tools we have to use and then the way we can time and think about things. Where you meet a surgeon in the care of neuroendocrine tumors is potentially at diagnosis. We often see patients with neuroendocrine tumors in the pancreas, in the small intestine, or even the lungs. And so thoracic surgeons, GI surgeons, or pancreas surgeons, we may be involved at that junction. Sometimes patients either present or develop liver metastases, which are the spread of the tumors to the liver, which is the most common place for this kind of tumor to spread. And actually, we have a lot of tools available to help patients in those situations, from the medications that Dr. Pata and Dr. Vijayvargiya will talk to you about or you may be aware of, treatments like Dr. Yu has in his armamentarium, treatments that Dr. Meyer and Dr. Lee can tell you more about, and then debulking surgery, where this is one of the few tumors where we can show you that patients will do better, even if we can't remove all the tumors in the liver. If we can remove 70 to 90% of them, patients can do better, and we can extend life significantly and leave room for further treatments. And we can get to know these patients for long periods of time, even decades. And so it's a real nice pleasure to be here to help you learn more about this type of tumor. I hope to answer any questions later on, and I'll turn it over to my next colleague.
Thank you so much, Dr. Castellanos. I think if you have a second, our patients would love to know. A lot of my patients ask me this question as to why we would do surgery in some cases with liver disease, but not in others when there's disease in liver and some other place too. And, how do you choose your patient as to who is going to benefit from debulking surgery? And when a patient should even ask, thankfully we are at an institution where we can we introduce and we discuss patients at tumor board and everybody gets your opinion. But how about if you don't have it, when should a patient think of that, hey, maybe I need to see a surgeon, even if they have advanced disease?
Yeah, that's a great question. In general, neuroendocrine tumor doesn't follow the disease like kind of rules that we think of other cancers. So other cancers, we think it spreads, then surgery is not an option, which is not the case for neuroendocrine tumors. In isolated circumstances, sometimes it may spread beyond the liver, and if things can be removed, then we'll entertain that as well. That's a reasonable and an experienced center. Furthermore, we need to assess these patients individually, because how you think about liver surgery for neuroendocrine tumors is a lot different than other cancers. And so we have to take into consideration the grade. You may be familiar with, there's grades 1, 2, and 3, and they kind of tell you about how fast the cells are growing in the tumor, and they give you some other characteristics. But for me personally, they give me a sense of how easily these tumors are removed from the liver. Without getting too far into the details of it, we have a variety of techniques to remove tumors in the liver without damaging too much normal liver around them, which enables us to remove tumors very efficiently, very safely, and quite effectively, whereas you couldn't do that with a different type of disease like primary liver cancer or a cancer that's spread from the colon or things like that. So there's no like quick and easy answer to that, should I see a surgeon or not? You probably should as the initial evaluation, either, in a clinic or as part of a multidisciplinary meeting, just so everyone can weigh an opinion. But really, I found that the care of neuroendocrine tumors is very, very highly individualized. And each patient pretty much has to have their own custom tailored treatment plan. Do we do this first or that first? When do we bring this in? And it's one of the situations where I'm very happy to wait, because patients do so well for so long. We have very effective medicines that can keep things at bay or static, as we call it, keep things so that the scans are pretty much the same every 3 or 6 months while the lanreotide is doing its job. And then we can decide if and when surgery to remove all or most of the tumors is the right thing to do.
Thank you so much. I really appreciate your input, and we really value you being part of our important team. The next person on our list is Dr. Shane Lee from Interventional Radiology.
Hello, I'm Shane Lee. I'm one of the interventional radiologists here at Fox Chase Cancer Center. And so my specialty is really focused on doing minimally invasive procedures for a variety of different reasons, including for cancer therapy. Specifically for neuroendocrine tumors, one of the areas that we really focus on is treating tumors that are in the liver. And so we do what we call either local regional therapy or liver-directed therapy. And the idea is that we can specifically target tumors in the liver for therapy. Generally, we have two tools to kind of deal with tumors in the liver. One is ablative therapy and one is transarterial therapy. And so ablative therapy is basically taking a probe, advancing it through the skin and using image guidance to target tumors that are in the liver. And once we place that probe in the exact spot that we want it to be, we flick on a machine at Fox Chase. We typically use microwave, and we do what it sounds like. We're basically cooking the liver tumor from the inside. It's a great treatment. Generally, the best candidates for this type of procedure are people who have sort of limited disease. It's sort of, the few things that we look at are really size of the tumor, the number of tumors, and then the location of the tumors. So depending on those factors will decide, whether this therapy is appropriate for each individual. Generally, for ablative therapies, we're looking at smaller tumors and fewer number of tumors, and tumors that are in safe areas of the liver, because the microwave probes can do damage to structures next to the liver. And so we want to make sure that the tumors are not in a location where we might damage a structure next to it. The second big category of therapy that we provide is what's called transarterial therapy. And this is a totally different approach to treating tumors in the liver. What we do is we actually will enter an artery, typically in the leg, and using X-ray guidance, we can get our catheters and wires up into the arteries in the liver. Once we're in the right spot, we take images, we try to locate the arteries that are feeding the tumors. So most tumors will require some sort of arterial supply to live. And the idea is if we can get into those arteries and block those arteries, we can basically decrease the blood supply to the tumors and kill the tumors that way. And so what we deliver can vary. So there are multiple different options. So depending on institutions, they may offer one thing or another. Here at Fox Chase, we generally lean towards what's called bland embolization. So what it is small little particles that are in the arteries, and they get stuck in the end arteries and basically kills the tumor that way. We can deliver material that has a little bit of chemo in there. The data, between one and the other generally hasn't shown that one is superior to the other. And so, it also depends on the expertise of the clinicians that are at your institution. The last thing that we can deliver is called Y90 or yttrium radioembolization. And this is a little bit different. These are beads that have radiation attached to them. And so after the beads get stuck into the arteries, so the tumors will suck up these beads and then they'll be exposed to high doses of radiation and basically kill the tumors that way. For neuroendocrine, we generally don't offer this as often because we're finding that you can get long-term side effects from the radiation. So oftentimes our neuroendocrine patients will live a little bit longer than some other tumor types. And so we're finding that we're seeing some late-stage, collateral damage to the liver that are next to the tumors. So in order to avoid that, we sort of try to avoid Y90 therapy. But in certain situations, it may be an appropriate therapy. So again, kind of the theme here is that, it's very individualized to the person. So in a nutshell, that's kind of what we have to offer.
Thank you so much. And as we all know, interventional radiology also is a part of our multidisciplinary tumor board discussions whenever we have patients with advanced disease and which kind of local therapy to provide. Is it surgery? Is it radiation? Is it interventional radiology procedures? Is decided at that moment. It's a very nuanced discussion. And as has been mentioned multiple times today, treatment has to be individualized. One patient is very different from the next one and very different from the third patient that comes along. So it's very important that we discuss each of our patients at every point. So thank you so much, Dr. Lee. Appreciate your time and all your expertise. He's always very helpful. I always call him from clinic when I have a patient who needs help, and he makes sure that the patient's seen and taken care of right away, follows up on them. So we really appreciate that from your side.
Thanks. Happy to be part of the team.
Thank you very much. All right. So let's moving on in the sense of more localized and local regional therapies. We will now have Dr. Joshua Meyer talk about how radiation can help patients with neuroendocrine tumors. We'll have Dr. Meyer talk next.
Hi, everyone. My name is Josh Meyer. I am a radiation oncologist, which means I treat cancers with radiation, and I really treat different kinds of gastrointestinal cancers, including neuroendocrine tumors. And what that means is we basically treat these tumors with X-rays using a machine from the outside, which is a little bit different than what Dr. Lee was just talking to you about in terms of treating with radiation from the inside. This has been a treatment that's been used for neuroendocrine tumors for quite a long time, actually. There are papers describing this all the way back to the 1960s. But primarily for the vast majority of that time, the radiation was used to treat patients palliatively, meaning if they had pain, if they had other symptoms, the radiation would be targeted at a particular tumor that was causing pain or nausea or things like that. And it was generally effective. I think most of the time, the radiation does work in treating neuroendocrine tumors. And so I've had a lot of experience with patients who have a tumor in a spot that's causing them pain, and they're sent to me by Dr. Vijay Verghia or someone else, and I treat them, and it's often quite effective. The interesting thing about neuroendocrine tumors that we've been talking about tonight is that they grow very slowly. And what that usually means actually in response to radiation is sometimes they shrink slowly too. So you sometimes have to be a little bit patient to get the response, but the response usually comes. The one thing that I wanted to mention that has been seen more recently in the literature, and also I've had more experience with it myself, is treating neuroendocrine tumors aggressively with radiation in order to actually control the cancer and slow the progression of cancer. That is something for which there hasn't been data since the 60s, but more recently we have seen a number of different studies that have shown this effect is actually quite strong. And so we have the opportunity now to treat patients not just palliatively to try to control symptoms, but also for what we call tumor control. So this means that we can treat someone with a liver tumor like Dr. Castellanos or Dr. Lee was talking about. We can treat someone with a tumor in the pancreas. Sometimes pancreatic neuroendocrine tumors become problematic, or sometimes they are the only site of disease and we want to treat them aggressively. We can treat patients who have disease that is spread to other parts of the body. And we can do that aggressively with an attempt to really control those tumors and keep them from growing. And so what we end up having, as you've heard, is multiple different specialties here, each of which might have a role in helping a particular patient. So it's really fantastic that we get to get together, discuss this with all of the colleagues you see on this call, as well as a number of others, and talk about what's going to be best for a particular patient. And sometimes it's even a combination. There are certainly patients where Dr. Lee and myself will say, listen, I think this tumor in the liver is better to be treated with microwave ablation, but that one is going to be better with radiation. And so we try to really mix and match and do the right thing to make sure that every patient is treated optimally. So it's really a pleasure to be a part of this team, to be able to put our heads together and come up with the best treatment plans for each individual patient. And it's really a pleasure to talk to you tonight and to share some of our expertise with you.
Thank you so much, Dr. Meyer. We appreciate it. So all of you have heard about all the local treatment options with this disease, be it surgery, be it radiation, be it interventional radiology techniques, and these focus or target special areas of the liver or the primary, etc. Now we're going to move to a treatment strategy which treats the whole body. We call them systemic treatment options. And even before that, there are some newer technologies that are out there that have basically changed the face of how neuroendocrine tumors are treated. So we're going to I'm going to introduce Dr. Michael Yu from our nuclear medicine division, and he's going to talk to you about all the exciting things he has in his armamentarium to treat these cancers.
Okay. I think I'm the only one with slide because the picture worth 1,000 words. And I worked in radiology as well. It's just a different division as Dr. Lee. So I'm going to talk about therapy for the whole body and also theranostics, which is the word put together with the therapy and diagnostic compound. We label with different things so we can do different diagnostic and therapeutic part of it. Next slide, please. So neuroendocrine tumor is a really rare disease. It's only 3 to 8 cases per million. And then it's a complex disease. As we all know, no single patient are the same. Next, please. And then we used to have an old technology for PET, for nuclear, and then the old scanners are really not good enough. This is the image we can do PET in 1970s. The only thing we can see is pretty much brain, heart, and bladder. And then next slide. In 1995, we start to have a tracer called OctreoScan, which is the somatostatin receptor compound we labeled with a nuclear tracer, so we can see the images from the front and back. Those are the 2 patients. The one on the left is pretty much unremarkable, and on the right, we see some spot in the liver. So sometimes even my family say, how can you do that? It's just all the spot. So the technology keep changing over time. Next slide, please. In 1995, we had actual scan. We had that for about almost 20 years. 2016 is really the good year. We have a new tracer. It's the same somatostatin receptor compound, but we labeled with a PET tracer. So we can see where the tumors are. And this is the same patient. On the left is the nuclear imaging. You can see a little bit in the liver and a little bit in the chest. With the new compound, you can see very clearly the tumor in the liver, in the chest, and then in the other part of the body. So this is a really powerful tool we have. Seeing is believing. And then the next patient on the right, nuclear scan was called within normal limit. On the right side, we see clearly lesion in the liver. So they gave us a good idea where the tumors are, what we need to do. And then the new tracer, new compound, makes the unclear clear and makes the invisible visible. Next one. And then we start thinking about, we use the somatostatin receptor, we labeled with the PET tracer so we can see it. Can we label it with a therapeutic tracer so we can treat the patient because the compound, they will go to the tumor site. And then we can use the imaging to select patient. On the top, everybody will go to the imaging. If the patient has marker, we'll go to targeted therapy. If they do not have a specific marker, they will go to conventional imaging. So this is really open a lot of doors. That's what the word comes from, theranostics. We see what we treat, and then we treat what we see. Next slide, please. And so this is a, cartoon about basically we have a compound called somatostatin receptor. They're gonna localize on the tumor surface. We have a connector labeled and connect with the radio tracer so we can do the imaging on the right side. And then we treat the patient with the same setup, but a different tracer. And then on the left lower quadrant, that's the imaging from the treatment dose. So we have much more tools than before, give us a good and better idea. Next, please. So this is the patient we treated even before FDA approved this one. On the first was pre-treatment. You can see the patient has a lot of lesions in the liver, spleen, and then in the chest. After one treatment, everything is still there, it's just a little bit less intense. And then when we finish the treatment, everything is much better. So we can have some good evaluation and give us, good idea the treatment really works. I think this is pretty much my slide. So we have the program, we use the imaging to select patient, and then we treat the patient with the radioactivity. And, we have a good team because we need coordinator. Karen gonna talk next. We have a dedicated nurse, and then we have nuclear medicine tech. Pharmacy gonna provide us with amino acid, and then we have a specialized place. And then it's a very good, successful program. I'm very glad to be part of that.
Thank you so much. I cannot thank Dr. Yu enough for helping us becoming the first. Actually, we were the first center in our greater Philadelphia area to offer the Lutathera treatments, once it got approved for our patients, because Dr. Yu made sure that everything went in line. So we really appreciate that. Thank you. And now we're going to introduce Karen Sheehan. Well, she needs no introduction, but she's basically the lifeline of our Lutathera or our PRRT program. So Karen, take the floor away.
Hi, thank you very much for letting me be part of this panel. I'm the Lutathera program coordinator, and there probably are several of you out there who have received this treatment whom I have met. And if you haven't, it may be offered as an option in the future. I collaborate with a very supportive team to make this type of treatment happen. It includes, of course, Dr. Vijay, Dr. Yu, radiation safety, the pharmacy, nuclear medicine, and all the infusion nurses. My first interaction with the patient begins after they sign the consent. And we work together to create a schedule for treatment. There's 4 treatments and they're 8 weeks apart. And the treatments are usually done on Thursdays and they last about 6 to 7 hours. We need to be mindful of national holidays to assure that the drug will be delivered. And also we take in consideration holidays or celebrations that the patients may be involved in, because there will be a set of precautions that they will have to follow 3 days after their treatment. I also review with the patient a PowerPoint presentation, which will help better explain how their treatment day will go. Dr. Yu and the radiation safety staff will meet with the patient either in person, virtually, or over the telephone prior to their first treatment. And during that time, Dr. Yu will go over their most recent diagnostic scans and the risks and benefits of this type of treatment. Radiation safety staff will go over their home conditions, such as their contact with others, and they will review a list of precautions that the patients have to follow. Each week, I'll send out a notification to the team members so that they can assure staff availability for the treatment dates. The day before the treatment, I call the patients to remind them what time they need to be here. They need to start hydrating that day, and there is no need to fast. They can bring snacks and drinks. They should wear comfortable clothing. And it's also a chance for the patient to ask any last-minute questions. The morning of the treatment, I meet the patient at the snack bar. They register at the infusion desk, and I provide them with an upcoming schedule, which includes their follow-up blood work, their next clinic appointments, the dates of their upcoming treatments, and I let them know that they're very welcome to call me if they have any questions about their schedule. There's 2 treatment rooms. They each have a lounge chair that's equipped with massage, heat, and there's a television. Also, there's a nearby bathroom. Once the treatment nurse calls them in for their treatment, they'll care for them for the rest of the day. The treatment nurse will start an IV in one arm, and that's for taking their blood and also for the administration of amino acids, which protect their kidneys from radiation exposure. If the blood work results are within the criteria for treatment, a second IV is started, and that's to administer the radioactive material Lutathera. As I mentioned, the treatment lasts about 6 to 7 hours, and that's because the amino acids have to run at least 4 hours following the administration of the Lutathera. Radiation safety staff has already prepared the room and the bathroom for possible radioactive contamination. They also monitor the patient's radiation levels to assure they can be released safely with instructions. They give them a wallet card to carry, and this has the information about the drug that they received, the date that they received it, and a contact. This is very helpful if the patient has an unexpected trip to an emergency room, and also if they plan to do any traveling. So as you can see, this type of treatment does involve a team, and my goal is to help the patient feel less anxious and also to give them a familiar contact in case they have questions. Thank you.
Thank you very much. We really appreciate you walking us through how this new treatment PRRT is offered to the patients. So after we move on from this new treatment PRRT, I think I'm going to introduce to you Dr. Suki Pada. to talk to us about what her role is in the Neuroendocrine Tumor program.
Hi, everyone. I'm so happy to be here with you this evening. So my name is Suki Pata. I'm a thoracic medical oncologist. So as part of that role, I, of course, focus on lung cancer, but then I also focus on two uncommon diseases, lung neuroendocrine tumors, as well as thymic malignancies. So when I'm talking about lung neuroendocrine tumors, I'm talking about the entire spectrum, from typical, atypical carcinoid tumors of the lung, all the way to the more poorly differentiated large cell, small cell neuroendocrine carcinoma. And then we know that neuroendocrine tumors can also occur in the thymus gland. So I also will see patients who have this very rare tumor. So I really appreciate the invite for being here tonight, and I'll join you back in the clinical trial section.
Thank you so much, Dr. Pata. We really appreciate you being here. So as we move on, it's now my turn to talk a little. I am, as you have heard, I'm one of the GI medical oncologists here at Fox Chase. I predominantly take care of patients with neuroendocrine malignancies here at Fox Chase. That's where my research and my clinical interests lie. And I am going to talk a little bit about, medical treatments that are out there for neuroendocrine cancers and in malignancies in general. The first thing I want to spend time on is how do we, not say or name these tumors, and it's very confusing. It's a whole spectrum of tumors, and in general, patients who have neuroendocrine neoplasms or neuroendocrine malignancies, that is the big bucket that involves all of these cancers in general. They are divided into two types. There could be a well-differentiated and poorly differentiated. The well-differentiated and poorly differentiated tumors are usually, the pathologist helps us identify these. So a pathologist has a very important role. So for patients, we definitely recommend them getting an opinion at a place where a good pathologist can read the pathology, because as an oncologist, I go by what my pathologist tells me. So it's very important we hear what kind of cancer this is. A well-differentiated neuroendocrine neoplasm and a poorly differentiated neuroendocrine neoplasm are called neuroendocrine tumors. So well-differentiated neuroendocrine neoplasms are called neuroendocrine tumors. If they have poorly differentiated, as in they're very, aggressive and very not well-defined cancers, and when they look under the microscope, they form the neuroendocrine carcinomas, which Dr. Pata also mentioned, the large cell type, the small cell type, and also mixed tumors, which have some features of different kinds of cancers. Those are very aggressive cancers. They divide very fast, have a higher grade when we talk about the grade 1, 2, and 3s that we talk about, and usually treated with chemotherapy. The well-differentiated neuroendocrine tumors are further divided into three types. You have grade 1, 2, and 3. That is dependent on how fast these cancer cells are dividing. If they're dividing slowly, you're grade 1. If they're dividing intermediate, you're grade 2. And if they're dividing faster, you're grade 3. And the well-differentiated tumors are the ones that are relatively slower growing, especially the lower grade of these tumors. So it's very important that we know these names. Carcinoid is the term that we use for neuroendocrine tumors that are usually arising in your intestines and the lung. The pancreas are usually not called carcinoid, but we are trying to get away from that name because these are not cancer-like, these are really cancers. Even though they're slower growing, it's cancer in slow motion, but it has all the things that cancer can do. In terms of other things that we want to look at when I see a patient is, obviously, if it is spread anywhere, then we look, so that helps us define the stage of the cancer. Then we look at if these are functional tumors or not, which means are the patients having symptoms from their cancer? So we have heard these are tumors that produce hormones, and those hormones, are they causing any symptoms? Patients have diarrhea, they have flushing, they can have extra production of hormones from the pancreas, which can make their sugars go up and down, or have them have severe diarrhea that can lead to kidney problems, or a tumor that produces so much makes the stomach produce so much acid that you get ulcers in the stomach. So there are different kind of hormones that these tumors can produce. And so we try to see if they're functional or non-functional. And then lastly, we look at whether they are somatostatin receptor expressing or not. And the best way to do that is by the PET scan that Dr. Yu mentioned to earlier today. And that all of these things help us identify the type of tumor or type of disease that we have to tackle. And then our treatments depend on that. So in terms of medical treatments, the first and the most effective treatment we have in our armamentarium is the shot that we talk about. People call it the hormonal shot, the once-a-month shot, the sandostatin, the octreotide. These are different names for it, but it's basically a drug that blocks the hormone production from these tumors and also cuts off the signal for these cancers to grow. It's somatulin or lanreotide, and sandostatin or octreotide are the two big ones that are out there. And we use these for our patients very often. It's the first line of defense for this disease. After that, if and when this stops working, and if we employ these local techniques of radiation and surgery and interventional radiology, but if not, if other medical treatments that come in, we ask Dr. Yu to step in with the PRRT or Lutathera that he talked about. That doesn't work, then we have other treatments in our armamentarium. There's a pill called everolimus or Afinitor that works for lung neuroendocrine tumors, works for GI neuroendocrine tumors, works for pancreatic neuroendocrine tumors. So it's a drug that is very effective in this cancer type. It's a targeted agent. Chemo typically doesn't work very well for the neuroendocrine tumors, except the pancreas. In pancreas cancer, we have an oral chemotherapy option called capecitabine and temozolomide that we use. It's also used sometimes in lung too, but for the most part, the most data we have for its use is in pancreatic neuroendocrine tumors. So that's a drug that's available. There's another drug called sunitinib, which is also approved for pancreatic neuroendocrine tumors. And through the continuum of disease, we use all of these drugs in at different times. I always tell my patients this disease is more of a marathon and not a sprint. The art of taking care of patients with neuroendocrine tumors lies in the idea of when to change and when not to change, or when not to jump onto the next treatment, because there is no free lunch in medicine. Every drug comes with side effects of its own too. And finally, there is a lot of newer, exciting things that are coming out that we're going to talk about in a little while. So these are all the medical treatments we have. You will see me during your treatment. If you come to FoxJS, we'll be part of the group, and we discuss all our patients at tumor board. We have a specific neuroendocrine tumor dedicated tumor board where our patients are discussed to ensure that we treat our patients to the best possible, in the best possible way. So thank you. So moving on, after my part is done, I'm going to talk about some of the other important team members who help us take care of these patients, who are not just targeting the tumor, but they take care of the special aspects which make these tumors special. So I'm going to introduce Dr. Pankaj Sharda, who's from our endocrine division.
Hello, everyone. I'm Pankaj. I'm an endocrinologist here at FoxJS, and I'm very, very glad to be part of this discussion and part of this team. For me, again, I'm an endocrinologist, so I deal with hormones, as you probably have been made aware of. For me, neuroendocrine tumors are very unique because they don't originate from a particular organ. Like lung cancers, they originate from lung cells. Thyroid cancers, which I deal with very frequently, they originate from thyroid cells. But neuroendocrine tumors, they originate from these special neuroendocrine cells. And depending on where they are, that's what causes the symptoms. So if they are from the pancreas, you will see the symptoms like, high insulin levels or glucagon levels. Depending if they originate from lung, you'll see shortness of breath and so forth. And similarly, if they are from the GI tract, you'll see symptoms like diarrhea and so forth. So definitely that's what fascinates me, because each case is unique. And each case needs tailored, individualized treatment, as you have heard from many other colleagues of mine. Previously, when we were all in med school, they were called as carcinoid, which was many times used interchangeably with neuroendocrine, which we really know it's kind of a misnomer, because as Dr. Vijay alluded to, they are not cancer-like, but they do really have cancer or malignancy or carcinoma-like potential. So that's something what we have learned over the years of this neuroendocrine literature study. So when I see a patient where we suspect neuroendocrine tumor, few things which as an endocrinologist, and I'm going to talk from the endocrine aspect for it, from the endocrine aspect for these tumors, is these are generally slow growing and the symptoms can be many times vague. So there is a short delay in the diagnoses depending on the severity of symptoms. As many patients we see in the clinic, say, for example, hot flashes, that's a subjective symptom. And it's very hard to provide any objective scale to it as opposed to flushing. which when a patient sees himself or herself in the mirror, they can see flushing. You cannot hide flushing. Similarly, as a treating physician, we can, these are the things we suspect in our screening thing. And so many times with neuroendocrine tumors, which I initially see during the screening phase, is 4 things. One, whether we can locate them. Is that they are coming from foregut, from lung or pancreas or some, those locations. And the second is the grading, which, earlier was alluded to based on the Ki-67 scoring. Lastly, staging, because all these things will determine treatment. And the final thing is whether they are functioning or non-functioning. If they are functioning, that's when we consider any kind of hormonal treatment for this. But the key here is early screening, because many times there is a huge delay, because loose stools can be subjective, hot flashes or flushing can be subjective. Although these are slow growing tumors, earlier diagnosis is the key in these tumors. And that's where our multidisciplinary team at Fox Chase is very, very helpful to provide, tailored, individualized approach, not only in diagnosis, but also in earlier treatment, which at Fox Chase, there is state-of-the-art treatment by our medical oncology, radiation colleagues, and IR colleagues. The final thing I would like to share with our patient population here is, whenever we have such rare tumors, there is a lot on internet and Google, and Dr. Google tries to answer everything. The one thing I have learned throughout my so far in my career is finding credible information. So whenever you're trying to Google about or find out any information for diseases such rare, try to go to credible resources, which there are plenty, and we'll be putting in our links also. So with that, I would like to pass it on to our next colleague. Thank you, everyone. Thank you.
Thank you very much, Dr. Sharda. Very important thing always, there are really great patient-friendly resources for patients with neuroendocrine tumors out there. NCAN, they're supporting our program today, and I think they have helped so many of my patients. We have other similar, like LACNETS, NANETS itself has a good program. So I think these are Caring for Carcinoid or carcinoid.org. These are different websites. And, I'm also talking to your doctor, and they can guide you to read which is a good website to be at. So it's very important. Thank you very much for pointing that. So we're going to move on to the most important part of our group is how does a patient get through these treatments? And Anjali Albanese from a social work group is going to talk to us about how we support our patients to go through this very difficult time in their life.
Thank you, Dr. Vijay, and thank you to all of you for joining us this evening. As you can tell by all the professionals who have spoken before me, we really do take a multidisciplinary approach to care here at Fox Chase. I am privileged and honored to be part of such an amazing team of professionals. My role on the team is different, as you can obviously tell, than everybody else you've already heard from. The role of a social worker is unique in the sense that we really focus on the emotional and psychosocial impact of a cancer diagnosis. Oftentimes people say the first thing they think about when they're told they have cancer is shock. It's this immediate feeling of, oh my gosh, what does this mean? What do I do? There's fear of the unknown. What's going to happen next? How do I tell the people that I love that this is what's going on? Sometimes that also means thinking about changes, changes in roles, changes in routines, changes in employment. Oftentimes there's also this very significant feeling of loss of control. How can I change what's happening right now? Or what are the choices I can make that will actually impact the situation in a positive way? Sometimes people tell me the first thing they think about is, how do I do this for my family? Wanting to be strong for others. If there are children involved, how do I talk to my children? How do I explain this to them? And then also, in couples, how do I talk to my significant other? How is this going to affect our relationship? So these are all things that oftentimes when patients talk about, they don't really know who to discuss these issues with. So they do oftentimes mention things to the doctors that are on their team, to the nurses that are caring for them. And sometimes people know that, if there's a social worker available, that maybe that's the person they want to reach out to. So one of the things I'd like to mention is that, people face a lot of different emotions when living with all types of cancer, but specifically neuroendocrine tumors. I recently read a study that said 60% of patients said that the disease had an emotional impact on them in some way. And that means a lot of different things to a lot of different people. The upheaval can feel never ending. You know, sometimes people think like, oh my gosh, I thought the hardest part was going to be just facing the diagnosis. But then it's, you know, figuring out the treatment and figuring out how the treatment fits into your life. And then what does all of that mean for you going forward? It can be a marathon of tests, of studies, of symptoms, of syndromes, of reporting the information back to the team so they can best figure out how to support and help you through this time. Most patients say they experience symptoms on a daily basis. It's helping people figure out how to keep a record of those so that they can inform their medical team. Emotions can change, and I often say it can change minute to minute, day to day, week to week, month to month. There's no really predicting. But it's just important to pay attention to that emotional impact. And this can be true for patients who are newly diagnosed all the way through patients who are survivors of many years. And some of the things I think about when I talk to patients is, you know, they'll say, well, what can I anticipate feeling? And so oftentimes the first word that pops into my head is feeling overwhelmed, because there's so much information, there's so many things you have to consider that oftentimes is, how do I sort through all of that? Also, there's feelings of, you know, denial, anger. Why me? Why did this happen? Why now? There's fear, there's worry, there's stress, there's anxiety. Somewhere in there, there's hope. And sometimes patients have even said there's some level of gratitude, which I know sounds funny, but people have said that, you know, it sort of helped them put their life in perspective, or maybe help them understand things in a way that they never thought they would. Sadness and depression is something, unfortunately, that, you know, kind of goes hand in hand when you're dealing with something as stressful as this. And oftentimes people even talk about feelings of loneliness. You know, everybody else seems to be feeling like they can go on and live their life the way they were before, and suddenly things feel very differently for them. So when we think about loneliness, there's a lot of different things we can consider. One is that's always a great time to possibly consider talking to a social worker. Part of our role is to be an emotional support person to our patients and the caregivers that are supporting them. Sometimes it's, you know, helping people figure out how to network with other patients. As you've heard everyone say before, neuroendocrine tumors are rare. And so sometimes people will say, you know, I don't know anyone else with this type of cancer. It's not like breast or lung where, you know, I can say maybe I do know someone. This is often unique in that way. And fortunately at Fox Chase, with the support of Dr. Vijay and Karen, we've been able to start a neuroendocrine tumor support group. And it's been running now for almost a year. Just hard to believe, but it's very well attended. So that's always something that's an option for people if you want to meet other patients going through an experience like this. There's also a program at Fox Chase called the Patient-to-Patient Network, where we can match patients up with someone who has also been diagnosed with the same type of cancer and who is maybe either currently going through the treatment or completed the course of treatment that's being recommended. And sometimes people say that's very helpful because it gives them some insight into what to expect. My tagline for everyone is always, you know, don't ever be hesitant to reach out and ask for support or help. That's what we're here for. We fully recognize that you are a whole person before you walk through our doors, and our hope is to help you feel like a whole person once again. And I always say to all of my patients, I'm the person to call when you don't know who else to call. If it's not me, my hope is that I can at least point you in the right direction. So thank you again for joining us this evening, and I really appreciate your time.
Thank you very much. Yes, another plugin for our support group. I think most of my patients who have been a part of it have only felt that that was the positive change, and the support they get is really worth it. So thank you, Anjali, for making that happen, and extend it to Mark as well. All right. So now we have met all our people. I just want to spend 2 minutes on talking about what's new at Fox Chase, what's up and coming in this disease. So we do a lot of clinical research as a part of our work. I have personally, invested myself in studies across the continuum of the GI and GEP-NET cancers. We recently closed the CABINET trial, which you all may have heard is a positive study of the use of cabozantinib. It's a new drug that the results showed that it improved patients' outcomes and time to progression in patients with GI, lung, and pancreatic neuroendocrine tumors. So it's a drug that's going to have a wide effect hopefully when it gets approved. So we had some of our patients were part of it. So thank you for being a part of that study. We currently have study trying to use an amped up version of PRRT. It's called the COMPOSE trial, where we are trying to recruit patients who are slightly higher grade. So patients who are more than 10% or 15% Ki-67, grade 2 and grade 3, well-differentiated neuroendocrine tumors, and where we're doing an amped up version of PRRT compared to standard of care. So we have that study open. If you have a patient, want to come out to see us. For poorly differentiated neuroendocrine cancers or the higher grade cancers, we currently have a study where we're combining a drug which sort of makes the cancer less resistant to chemotherapy. So we give it with chemo, and here we're trying to see if it will make the chemo work longer or last longer for those patients. So that's a very unique study. There's very few. There's probably 1 or 2 national studies that happen for high-grade neuroendocrines, and we are fortunate we have one of them here at our center. Actually, we are doing it ourselves. And then I'm going to let Dr. Pata talk about a lung neuroendocrine tumor study we have, which we are going to have pretty soon.
Yeah, thanks so much. So as you know, with lung neuroendocrine tumors, hopefully it changes now with the cabinet study, but we only have one FDA-approved therapy for advanced lung neuroendocrine tumors in the form of everolimus. And really, the only way that we can add more therapies to our treatment toolbox is by running clinical trials dedicated in this patient population, and then of course having our wonderful patients volunteer for these trials. So myself, as well as my co-chair, Dr. Tom Hope, who's a nuclear medicine physician like Dr. Yu, are running nationally a trial in somatostatin receptor positive lung neuroendocrine tumors, comparing the radiopharmaceutical Lutathera, PRT, versus the standard of care everolimus. So we're trying to see if this radiopharmaceutical is better than what we have for the standard of care, because as many of you know, the NETTER-1 study, which resulted in Lutathera approval, did not include patients with lung neuroendocrine tumors. So we really want to understand how this therapy works for our patients with lung neuroendocrine tumors. So I'm going to be collaborating very closely with Dr. Yu and Karen and their entire team as we get the study activated at Fox Chase. The other thing that I'd like to highlight is that when we were designing the study, it was very important for us, if a patient was randomized to the everolimus arm, that they got the opportunity when everolimus stopped working to cross over to Lutathera. So even if a patient ends up on what you can get per standard of care, you still have the opportunity to be able to cross over when it's needed to the Lutathera arm. So we're very excited to have that. Hopefully it will be activated, I'm hoping, in the next few months. And then I think this will really answer a very important question for our patients, how this therapy works. Thank you so much.
Thank you. So as you can see, we have standard treatment options, and there's a lot of clinical trials that work along the spectrum of the different neuroendocrine neoplasms that are out there, as we talked about. So I think it's an exciting time for us to take care of patients with neuroendocrine malignancies and all the exciting new drugs coming out. There's oral drugs, oral pills coming out for somatostatin analogs instead of that, which we are all waiting to see the results of. So I think it's a good time to be in the field, and we are really excited for our patients too. So here we end our part, and now we're going to start questions. So we got a few questions. There's actually a few of you who want to know what histotripsy is, and will Fox Chase be using it? So I'm going to ask Dr. Lee to talk and educate us about that.
Yeah, so histotripsy is a very new technology. It's very fascinating. Basically, it's different than the stuff that we have been using currently. The idea is using very focused ultrasound and these kind of very high energy pulses. You can direct it at certain parts of the body. So I would imagine this would be used in, say, a tumor in the liver. You can target that tumor in the liver with this ultrasound, and it creates these micro bubbles in a specific area that you choose. Once those micro bubbles are formed, then using very high frequency, you can actually expand and contract those micro bubbles, and that very high shearing effect will actually cause cell destruction in that, what they call a microbubble cloud. and it basically kills all the tumor in that one area. And so it's very interesting. Some of the benefits compared to, say, ablation is that it's non-invasive, so there's no needle puncture or anything like that. So just an ultrasound on the outside of the body. There's no ionizing radiation, so you don't have any of the side effects from radiation that can occur there. And the last thing is it's not heat-based, so there's some advantages of not using heat compared to, say, microwave. And maybe safer around certain tissues. Also doesn't have some of the issues with heat-based technologies where if you're near certain structures, say like a blood vessel, sometimes you can't get the temperature up high enough because the blood vessel is carrying heat away. Now with histotripsy, you won't have that issue. And then the last thing, it not being heat-based, is that with heat-based ablations, you're kind of destroying all the molecules that are in that area. With histotripsy, because you're disrupting cell membranes and killing cells that way, you're actually leaving some of the surface antigens intact. And so the idea is that some of those antigens can be exposed to your own endogenous immune system. And so you can actually train your own, your body's immune system to attack cancer cells by leaving some of those antigens intact. So something very interesting that's really coming along the pipeline. It's very new. Most of the early research, I think, is done at Michigan. It just got FDA approval for commercial use. And so this is something our department definitely is looking into. There's definitely still a long way to go in terms of data, but I imagine this could be something that becomes part of our armament of tools for cancer therapy.
So one more exciting thing to add to our armamentarium. Thank you very much. The next question I have is for Dr. Meyer. How big do you think the tumors need to be a candidate for radiation treatment?
So there's not really a size in terms of too small or too large, frankly. It all has to do with, like we have been saying, the individual patient, how each tumor is affecting you, whether it's bothering you, whether it's painful, where it's located compared to other tumors or parts of the body that we are trying to keep safe. And so I can't give you a particular number, but you're welcome to come see me and we can talk about if it's right for you.
Thank you. Thank you very much. There's a question about Dr. Castellanos. What can be done to a tumor causing a blockage in my small intestine? Is like, in general, if they are causing physical blockage, what kind of options do we have for those patients?
Yeah, it's a good question. A lot of times that's the first thing patients notice with neuroendocrine tumors. And it really depends. Is that the only area that there's a problem, or are there many, many other areas that there are problems? Sometimes we have to just address what's causing symptoms. And so you can do, either if you can't remove that piece of small intestine, you can do something called a bypass. And really, you need so much small intestine for your intestine to function normally. About 50 centimeters if you've got an intact colon, 100 centimeters if you were missing part of your colon. So that comes into the equation as well. So if you have one single tumor, or that's a focal area causing obstruction, typically surgery to remove that area is recommended. If you've got many areas of tumors where maybe that's the only one that's causing symptoms, sometimes we'll see what we can do just to relieve those symptoms without doing too much aggressively, because again, if everything else is stable on the medicines you're on, lanreotide or whatever, we're not in a rush to kind of do the aggressive thing in that situation. So it can be really tailored to your specific circumstances. So if isolated surgery, if not, depends is the short answer.
Thank you very much. So you have options. You need to talk to a surgeon. That's important. You may or may not, always seeing more providers is a better answer. The next question is, it's a little more complex, but I'm going to just generalize it for the sake of a common platform, is would you treat with PRRT if the patient has had prior Y90? And if so, what are your thoughts about that?
We have done that, and then I think there is a safety data really not a major issue. What we do is we can do imaging for everybody. So we need to have tracer positive tumors, and then we like to have a tracer uptake have a higher intensity than the liver. Actually, the higher the better, because we know the tracer gonna go in there, do the work. So we have this tool, we're really excited about it, And then sometimes from the imaging, we have a good idea if they can respond or not.
Thank you so much. That's a small right answer. Obviously, PRRT works on the liver and also works if you have disease outside the liver. So that is the advantage of it, that if whereas Y90s mostly can be done if the disease is limited to the liver or liver dominant disease. So the next question I'm going to pose it to Dr. Sharda. The question is are neuroendocrine cancers hereditary? And you may want to talk about like the some of them which are hereditary.
Yes, that's a very interesting question, actually. So the question, I believe, is the role of genetic testing. That's where it's leading to. So not all are, but depending on where you are, or where the origin is and what type you are dealing with. Like something like MEN1 syndromes, right? So they don't present directly with the pancreatic tumor. In most of the cases, they come to us first with hyperpara. Other neuroendocrine forms could be VHL-like of things, that or pheoparagangliomas. So I think it is a very individualized approach in such cases. It's a very hard term to say like all neuroendocrine tumors should get genetic testing, but depending on the constellation of syndromes they present with, I think there is definitely a role for genetic testing in certain types of neuroendocrine tumors.
Predominantly pancreatic neuroendocrine tumors.
Yes.
There's definitely much more likelihood of I typically send most of my younger pancreatic neuroendocrine tumor patients for genetic testing, talking about the syndromes that Dr. Sharda just mentioned. So the next question, which maybe I can answer, is the question of the RADIANT-4 trial. For those who don't know, we have a very educated viewer here. They were asked, that is the study which showed that everolimus is effective in patients with GI and lung neuroendocrine tumors. So here they're asking, do we have long-term data about this in patients who live longer than typically we say the benefit is 11 months. So I can, in the big study, which we compared the two, at about 2 years, there were 25% of the patients who were still controlled in their disease on this drug compared to what we typically call 11 months. So there is 1/4 of the patient had prolonged disease control on this drug. So this is an effective treatment, one of the effective treatments, than different things that are out there. So we're really running out of time now. There is one patient who asked a question. There's one viewer who asked a question: can fatty liver affect the treatment choice for local therapies to the liver? So I am going to ask Dr. Lee to answer that question, I guess, and Dr. Castellanos can chime in too.
Yeah, so one of the things that we do pay attention to before providing liver-directed therapy is the underlying health of the liver. And so we want to make sure, because there is going to be some collateral damage to normal liver. And so we want to make sure that you have enough healthy liver to withstand the treatment of the tumor. So fatty liver in itself typically won't exclude most people from liver-directed therapy, but there are certain tests and markers that we do to look at the underlying health of the liver to make sure that you're a good candidate for the therapies.
Yeah, and to build on that, with the well-differentiated G1 tumors, interesting, I'll talk shoppy a little bit just so you kind of know what it's like to operate on them. These tumors want to be removed from the liver, and so you can just stay right on them, and they're like little gumballs that kind of spread out. And so I can remove 20, 30, 40 tumors in a patient if they're in appropriate locations. And the liver, how much actual liver I'm removing is a very small amount. And so the recovery can be very good. And like Shane said, fatty liver is not a problem unless it's causing underlying liver dysfunction leading to cirrhosis, and then that's a fragile liver, and then those livers can be really dangerous to deal with if there is a risk of tipping into liver failure. Not typically seen in this patient population, just for whatever reason. It's just not the risk factor profile. It can be the case of liver dysfunction later on after many, many lines of treatment, but at that point, we're not really thinking about aggressive options to the liver beyond like 1 or 2 specific tumors that might be growing on treatment. So it's a good question, but it hasn't really been an issue for myself, Shane, or Josh, I don't think.
Thank you so much. We really appreciate your time. And unfortunately, that's all the time we have today. We had a fun discussion. It was very informative for me too. So thank you everyone for spending the time with us, spending your evening with us. We would like to thank our panelists. We would like to thank our exhibitors and the advocacy organization for the support, and to all of you for joining us tonight. This concludes our Together Facing Cancer series for the fall, and we will be announcing our spring topics in the new year. We wish you all a very happy holiday season. Good night and take care.